Hello there. We'll be talking about glomerular filtration and renal blood flow in this lecture. By way of introduction, I would just say that we'll mention some things briefly about the renal anatomy. Um, it's a most interesting organ, the kidney, because the two kidneys receive about 20 to 25% of the cardiac output, and as the kidneys are only about 0.4 to 0.5% of the total body weight, it means that they receive the highest blood flow of any organ in the human body, and the entire plasma volume is cycled through the glomerular system about 20 times in 1 hour. Now, the blood flow through the kidneys are not homogeneous, right? About 90% of it goes through the cortex. Now, the functional component of the kidney is the nephron, and each kidney contains about 1 million of this. The nephron consists of the renal corpuscle, which is simply the Bowman's capsule, together with the invaginating glomerular capillary tuft. These cartoons show what we're talking about. The cartoon on the left shows a broad overview of a prototypical nephron. Right, this is the renal corpuscle here. Then we can see the ducts, the proximal convoluted tubules, the loop of Henle, distal convoluted tubule, as well as the collecting ducts. Now, the cartoon on the right shows a schematic representation of a renal corpuscle. You can see the afferent arteriole. Blood enters into the glomerulus through the afferent arteriole and eventually leaves the glomerulus through the efferent arteriole after filtration must have occurred, and the filtered urine collects in the capsular space. From there it passes to the proximal tubule. Now, the glomerular tuft has three different type of cells inside. We have the mesangial cells, the endothelial cells of the capillary, as well as podocytes. We'll talk more about these cells later. Now, the second part of the nephron is the tubules, which we already know that there is a proximal portion, a loop of Henle, and the distal portion. Okay, then finally we have the collecting duct system. Okay, now you should note that the after age 40, the functioning nephrons, they decrease about 1% every year. That's about 10% every 10 years. All right. However, there are adaptive changes that allow the remaining nephrons to still do the proper functions of the kidneys. Now, there are two types of nephrons. There are cortical nephrons and juxtamedullary nephrons. Cortical nephrons are so called because they have their glomeruli in the outer cortex. They have short loops of Henle, and their peritubular capillaries carry nutrients to the tubules. They account for about 85% of all nephrons. Juxtamedullary nephrons, their glomeruli are also in the cortex, but in the inner part of the cortex, quite close to the medulla, and that's why they are called juxtamedullary. They have long loops of Henle that go deep into the medulla, and they are the particular nephrons that are involved in the concentration of urine. The efferent glomerular capillaries form the vasa recta, which functions as countercurrent exchangers. We'll be discussing this in other lectures when we talk about the concentration of urine. All right, so they account for about 15% of all nephrons. Now, the renal corpuscle itself, right, is simply formed by invagination of a capillary of the afferent arterioles into the Bowman's capsule, right? And two cellular layers separate the blood from the glomerular filtrate. There is the endothelial endothelium of the capillaries itself, plus some specialized epithelium of the capsule. It is noteworthy that the endothelium of the glomerular capillaries is fenestrated. Fenestration just means that it has holes or pores, and these are about 70 to 90 nanometers in diameter, right? And so when filtration occurs, the plasma passes through the fenestra of the capillary endothelium into the and across the other components of the filtration membrane. Now, the endothelium of the glomerular capillaries is surrounded by glomerular basement membrane, all right, along with podocytes that we referred to earlier. Podocytes are just specialized epithelial cells which are which form part of the filtration membrane. They have numerous pseudopodia just like amoebas have. All right, and this pseudopodia, they interdigitate, they link up together to form filtration slits along the capillary wall. We'll talk about more about this later in this lecture. All right, so this cartoon shows some of what we've been talking about. All right, so as before, you can see the afferent arteriole that goes in, forms the capillary inside the nephron, and eventually it exits. It takes blood out through the efferent arteriole. All right, now we on the external surface of the capillaries, we can see. What we can see here are podocytes. For instance, this is a podocyte. You can see its nucleus. Its nucleus is this oval feature here. So this is one podocyte. This is another podocyte, right? And we can see their pseudopodia extending and covering most parts of the capillaries, but there are spaces in between which we'll talk about. So now there's a cut section of this at this point, which is illustrated here. So we can see the lumen of the capillary, right? And in the space between them are mesangial cells, right? Which I referred to earlier, right? As one of the population of cells within the glomerulus. All right. So now we can also see the filtration slit. We said that the podocytes extend their pseudopodia to cover the surface of the external surface of the capillaries, but there are spaces in between these pseudopodia which are referred to as filtration slits, right? So these are illustrated here as well. All right. Then finally, we should note that the okay, yes, you said this already. Podocytes wrap their projections around the endothelial cell of the capillaries, and they thus form the inner wall of the capsule. That's the visceral layer, whereas the parietal layer, which forms the outer wall of the capsule, consists of simple squamous epithelial cells. Okay. Now, fluid filtered from the capillaries, glomerular capillaries, enter into the capsular space or Bowman space, and anatomically the glomerulus along with Bowman's capsule is referred to as Malpighian corpuscle. All right, so the renal corpuscle is referred to as a Malpighian corpuscle. Okay, now the proximal convoluted tubule cells have a columnar epithelium with millions of microvilli that have brush border. The brush border will increase the surface area, just as the intestinal cells, intestinal luminal cells have a brush border for increased surface area to facilitate absorption of digested food. So in this case, the brush border facilitates absorption of water, nutrients, electrolytes reabsorption back into the blood. Now, the distal convoluted tubule cells have cuboidal epithelium, but they have few microvilli with no distinct brush border. Finally, the distal convoluted tubule and collecting duct are made up of two populations of cells. We have the principal cells, which have receptors for antidiuretic hormone and aldosterone, and they are involved in sodium and water reabsorption. And we have the intercalated cells, which are involved in acid-base homeostasis within the kidneys. All right. Now we need to talk about a group of cells that are referred to as juxtaglomerular apparatus. This is simply a specialized region of a nephron where the afferent arteriole and distal tubule comes into contact. Again, in case anyone is still not sure what my afferent or efferent arteriole is the arteriole that brings blood, that leads into the glomerulus, right? So it is the arteriole through which blood enters the glomerulus to be filtered, whereas the efferent is the arteriole through which is a continuation of that, is the post-capillary arteriole through which blood exits the glomerulus. Now, the juxtaglomerular apparatus consists of three components. We have the juxtaglomerular cells, the macular denser cells, and the extraglomerular mesangial cells. Yes, we've referred to the mesangial cells earlier. Now, this cartoon, we can point them out now. Anything within the Bowman's capsule, right, we can refer to them as intraglomerular, right, whereas any structure outside is extraglomerular. Right, so we can see within Bowman's capsule, we can see labeled here intraglomerular mesangial cells, right. They are one of the cellular populations within the Bowman's capsule. Right. So, but there are some similar cells to these mesangial cells that lie outside the confines of the glomerular, lie outside the confines of the Bowman's capsule. All right. So these are the extraglomerular mesangial cells. So this extra and the intraglomerular mesangial cells, they have similar. They are identical and do similar things. So, but say a population is within the capsule, the second population is outside the capsule. Now, the juxtaglomerular cells, also referred to as JG cells, they are modified smooth muscle cells of the afferent arteriole, right? And some of them contain renin, and they are sympathetically innervated. So it means that sympathetic stimulation can cause them to release renin. All right. So they are sympathetically innervated granulated cells which function as mechanoreceptors. All right, to sense blood pressure. So let's go back and look at them. These are the juxtaglomerular cells as indicated, and you can see how they are closely opposed to the afferent arteriole. Now, the macular denser cells, they are epithelial cells in the distal tubule, right, at the junction of the thick ascending limb of the loop of Henle and the distal convoluted tubule. All right. So there's a point where the thick ascending limb of the loop of Henle becomes the distal convoluted tubule. So it's at that junction, at that exact junction, that is where the macular denser cells are located. All right. So they are they are located within they form part of the lumen of the distal tubule. Okay. Now, still on the macular denser cells, yes, they are also in direct contact with the vascular pool of the glomerulus. Yes, we can see this here. They had again the vascular pool refers to the two arterioles, both the afferent and efferent. So we can see they are closely opposed to both the afferent and efferent arterioles here. Okay, they function, that's the macular denser cell, they function as chemoreceptors because they can sense changes in the salt concentration, specifically sodium chloride, of the distal tubular fluid, and they send signals to glomerular vascular elements to help regulate blood flow, glomerular filtration, and renin release. We'll talk about this later. And finally, we have the extraglomerular or juxtaglomerular messenger cells. They are found between the afferent and efferent arterioles. They cause selective vasoconstriction because they have smooth muscle. They are specialized smooth muscle cells. They can when they contract, they cause vasoconstriction of the arterioles which they surround, right? So the function of the juxtaglomerular apparatus, the juxtaglomerular cells, also called granular cells, they produce renin as part of the renin-angiotensin-aldosterone system. All right. The extraglomerular messenger cells, they regulate the glomerular filtration rate by altering the vessel diameter. As I said earlier, that they can contract and cause vasoconstriction, whereas the macular denser cells respond to changes in the sodium chloride concentration in the distal tubular fluid. All right. Now, some functions of the kidneys: they have excretory and regulatory functions, removal of nitrogenous waste products, maintenance of water electrolytes and acid-base balance, regulation of extracellular fluid volume, and so on. We also have metabolic because they are involved in gluconeogenesis, and as well as endocrine functions, production of renin, erythropoietin, and other hormones. All right. So let's now talk about renal circulation. The renal artery divides into two, anterior and posterior branches, right? Now, this is an anatomy this is a physiology lecture, so we'll not be dwelling too much on the anatomy. I believe you already know most of this. All right. So these anterior and posterior branches will subsequently divide to supply every part of the kidney, and they divide into this into several orders of branches which are listed here and shown better in this schematic. All right. Now there are some important things to note. Some interesting things about the renal circulation. The kidney is unique in that it possesses two different capillary networks, which are connected in series. Right. These are the glomerular bed and the peritubular capillary bed, which are separated by the efferent arteriole. Okay. And we should also note that the pressure of the glomerular capillary, right, is much higher than that of any other capillary bed in the body. All right. The reason for this is not far-fetched. For successful filtration, you need a high pressure, because it stands to reason that if you are trying to filter a fluid through a membrane, the higher the pressure of the fluid that is impinging on the membrane, then the faster the filtration process will go. And this is the reason why the glomerular capillary pressure has to be quite high. Alright, so now let's talk about the two capillaries. Yes, the first is the glomerulus, which we've talked about earlier. So there is an afferent arteriole which feeds it, and it is drained by an efferent arteriole. And the blood pressure is high in the glomerulus because the arterioles are high resistance vessels, and afferent arterioles have a larger diameter than efferent arterioles. So it means that the diameter of the incoming arteriole is bigger than the diameter of the outgoing arteriole. Now the second capillary is the peritubular bed. These are low pressure, and they are porous capillaries which are adapted for absorption. Right? So they arise from the efferent arterioles of the glomerular capillary. All right, and they empty into the renal vascular system. The vasa recta are the peritubular beds of juxtamedullary nephrons. So we should note that when we say vasa recta, They are simply the peritubular capillary beds of only the juxtamedullary nephrons. The peritubular capillaries of cortical nephrons are called just that, just peritubular capillaries. All right, so this cartoon shows what we're talking about. All right, so we can see this is a juxtamedullary nephron to our right. The first one on the left here is a cortical nephron. All right, so we can see the afferent arteriole here entering into the glomerulus, and can see the efferent. All right, so this is its peritubular capillaries. All right, now for the juxtamedullary nephron, we can see the similar thing. This is the afferent arteriole, and its peritubular capillary is referred to as a vasa recta. All right, now afferent and efferent arterioles, they offer high resistance to blood flow. As a matter of fact, blood pressure declines from about 95 millimeters of mercury in renal arteries to 8 millimeters of mercury in the renal vein. All right, now the high resistance in the afferent arterioles protects the glomeruli from fluctuations in systemic blood pressure. All right, so it means, okay, we'll talk about the regulation of renal blood flow later. Now, the resistance in efferent arterioles also reinforces the high glomerular pressure and reduces hydrostatic pressure in peritubular capillaries. All right. Okay. Now, the afferent and efferent arterioles, they, as we'll see, they help to regulate the hydrostatic pressure in both sets of capillaries because the hydrostatic pressure is the key factor that drives filtration, as we'll talk about more. So high hydrostatic pressure in the glomerular capillaries cause rapid fluid filtration, whereas a lower hydrostatic pressure in the peritubular capillaries, right, and vasa recta, they permit rapid fluid reabsorption. So by adjusting the resistance, right, the kidneys can adjust. They do adjust the resistance of the afferent and efferent arterioles, and thereby regulating the hydrostatic pressure in both the glomerular and the peritubular capillaries. So it simply means if the body needs to increase the glomerular filtration rate, right, the rate of filtration, say perhaps in response to an increased water load, say somebody drank too much water, or a patient that was given too much IV fluid, and the body senses that there is a fluid overload and it needs to get rid of fluid as quickly as possible. All right, so it's possible for the kidneys to increase the rate of, because the higher the glomerular filtration, the faster urine will produce, right, and the faster the excess water load can be excreted. All right, so the kidneys will increase the glomerular filtration by increasing hydrostatic pressure, and it does this by adjusting the resistance, basically by either vasoconstricting or vasodilating the arterioles of the glomerular capillaries. All right. Okay, now some characteristics of the renal blood flow before we talk about glomerular filtration in detail. It's very high, as we've said earlier, about 600 to 1,200 mL per minute. The arteriovenous oxygen difference is quite low, just about 1.5 millimeter per deciliter. So this is the level. Saying that the oxygen level in the arterial part of the renal circulation is not much higher than the oxygen level in the venous part of the renal circulation. So it simply means that while while there is the metabolism, it implies that the metabolism that happens in the kidney between the renal artery and the renal vein is there is metabolism, but it's not significant enough to is not enough to significantly reduce the to significantly consume oxygen. Right now, during exercise, the renal blood flow can increase up to 1.5 times. The renal circulation has a low basal tone now, and which is not altered significantly in denervated or innervated kidney. Now, concerning this, we know that most all vessels, right, generally in the body, they are under autonomic. They have autonomic innervation, right, and generally they have a slight sympathetic inflow to them at all times. So they are all in normal times they are always a bit tonically. They are under influence of sympathetic stimulation at all times, right, which keeps which keeps them slightly vasoconstricted at most times. Now, this can be relaxed to cause vasodilation, or the constriction could actually be increased if the sympathetic outflow to these vessels increase. All right. So we are saying that for renal vessels, this sympathetic tone is actually quite low, and so there is not much difference if you are to denervate a kidney, right? If you are to cut off the innervation to a kidney, then you will not notice too much difference in what happens, because even when the innervation was still intact, the autonomic stimulation of the vessels was not really much in the first place. Now, another thing is that the VO2, that is the volume of oxygen. Now, VO2 signifies the volume of oxygen consumed. All right. So the VO2 in the kidneys is directly proportional to the renal blood flow, sodium reabsorption, and glomerular filtration rates. And as we said earlier, the blood flow is not homogeneous. It is more about 90% or so of the total renal blood flow goes to the cortex. All right. And the vasa recta, the hairpin bend of the vasa recta is necessary for the hyperosmol, for the high osmolarity of the inner medulla. Okay, so, and it's been found out that in transplanted kidneys, that the blood flow to the cortex does not show autoregulation. All right. Blood flow to the cortex shows autoregulation, but not medullary blood flow. All right. So blood flow to the cortex in transplanted, in a transplanted kidney has been removed from a donor and inserted in a recipient. All right. So it's in found out that there is still we'll talk about autoregulation in this lecture. So it's found out that autoregulation still happens in the cortex of transplanted kidneys, but not in the medulla. All right. Now, okay. So let's now talk about the effects of renal circulation on urine production. All right. Now, it stands to reason that we know that the filtered plasma from the blood in the glomerular capillary is what we refer to as urine. Of course, immediately after it is filtered, it still undergoes several processes before it gets down to the bladder for excretion, right? So, but once that plasma is filtered, it has become urine. Now, that urine will be adjusted. There will be secretion, there will be reabsorption of water and electrolytes and some nutrients and so on, but it's already called a urine. All right. So it stands to reason that the glomerular filtration rate will be important in determining solute and water excretion. All right. Okay. You should also note that the peritubular capillaries they return reabsorbed solutes and water to the systemic circulation, right? And the vasa recta capillaries also return reabsorbed salt and water to the systemic circulation and participate in the countercurrent mechanism. Again, the countercurrent mechanism is a mechanism that is involved in the ability of the urine to ability of the kidney to concentrate urine. All right. So let's talk briefly about processes involved in urine formation. Right. The first, of course, is glomerular filtration, which we have talked about briefly. All right. So basically, urine is an ultrafiltrate of plasma. All right. Filtration is driven by Stirling forces. We'll talk about Stirling forces soon. And about 180 liters of glomerular filtrate is formed daily, but almost all of this, about 99%, is reabsorbed by the tubules. Okay, the glomerulus function as size selective, shape selective, and electrical charge selective barrier for macromolecules. All right, so because of the nature of the filtration barrier, right? For instance, we talked about the fenestrations of the glomerular capillary endothelium. We said they were about 70 to 100 nanometer in diameter. All right, so what this means is that any molecule, for instance, any molecule or within the blood in the glomerular capillary that is bigger than 100 nanometer in size will not be able to pass through, will not filter through, right? And and we know that a lot of protein molecules are big, they are far bigger than that. So that is one reason why proteins, that in the normal course of things, in normal health, in good health, the amount of protein in the kidney, in the urine is very, very little, because most protein molecules are macro, they are large, they are macromolecules, they will not pass through. All right, so that's the size selective function of the glomerulus. Then shape as well, and electrical charge, because there's a negative charge to most of the components in the filtration barrier. All right, and we know that unlike charges, like charges repel. All right, so again, using protein as an example, protein negatively charged macromolecules. So even if the size of a particular protein molecule was small enough to pass through the filtration barrier, the fact that it's negatively charged and the filtration barrier is also negatively charged will tend to repel, will tend to inhibit its passage through the filtration barrier. All right, so normally the filtration barrier is not permeable to molecules that are as big as albumin or larger. All right, cations are more readily filtered than anions, because cations are positively charged ions. All right, now the ultrafiltrate passes through the tubular aspect of the nephron to eventually form urine. Okay, now the glomerular filtration barrier, as we've said, its size and charge are selective. Okay, molecules that are smaller than 1.8 nanometer are freely filtered. More than 3.6 nanometers are not filtered. So between 1.8 to 3.6 nanometers, cations are filtered, anions are not filtered, because at this intermediate level, right, the size of the molecule or cation is sufficient to actually pass through. So, but it's sufficient, but it's not it will still be as it were a tight fit. All right, so at this point the charges will now come into play. All right, if they are negatively charged ions, if they are anions, then the charge on them the negative charge in the filtration barrier will repel this negatively charged ions that are trying to pass through pass through the filtration slit that is of barely sufficient size to allow them to pass. Now, charges. Yes, we've said that all layers of the glomerulus contain negatively charged glycoproteins, and this restricts passage of other negatively charged proteins. There's a clinical correlate here. There are several glomerular in a disease condition called glomerulonephritis, where these negatively charged glycoproteins are destroyed. We find out that proteins, you know, macromolecules like proteins are able to pass. Anionic macromolecules like proteins are able to pass, right? Because the negatively charged glycoproteins in the filtration barrier that should repel them have been lost, and so the patient has proteinuria. Proteinuria is the passage of protein in the urine. Okay. All right. Now the second part of urine formation is tubular reabsorption. All right, during which solutes and water, nutrients, electrolytes that were filtered through the Bowman's capsule are reabsorbed back into the peritubular capillaries, right? And tubular reabsorption may be active or passive. Okay, most of the reabsorbed substances are reabsorbed in the proximal tubule, about two-thirds. Okay. Now the third process is secretion. So there are some things within the blood that yes, they might have been, that will still be secreted from the peritubular capillaries into the tubule. All right, and this is usually the result of active transport. There might be some passive transport, but most of it is due to active transport. Only a few substances are secreted. There are many drugs that are eliminated from the body by tubular secretion into the urine. And finally, excretion. Excretion is just the culmination, the culmination of the first three processes. Anything that is not reabsorbed, right, is eventually excreted in the urine. Any substance in the filtrate that is not reabsorbed is excreted in the urine. All right. So glomerular filtration refers to the process of ultrafiltration of plasma from glomerular capillaries into the Bowman's capsule, right? And it is a chief measure of kidney function. It's a chief measure of kidney function because if we acknowledge that the chief function of the kidney, the primary function of the kidney is to filter the blood, right, in the glomerular capillary, right, for excretion of waste products and for reclamation and reabsorption of needed nutrients. All right, so filtration is the chief measure of kidney. If you want to check if the kidneys are functioning well, then glomerular filtration is the primary thing to assess. All right, now the filtration membrane, as we've said earlier, is formed by three layers: the fenestrated endothelium of the glomerular capillaries, the basement membrane of Bowman's capsule, and the podocytes, which form the visceral epithelium of Bowman's capsule. Now, glomerular filtration rate is simply the volume of filtrate produced by both kidneys per minute. It's about 125 mils per minute in men, and about 105 mils per minute in women. That's about 180 liters per day in men, 150 liters per day in women. All right. All right. So, measurement of glomerular filtration rate. It can be measured by clearance techniques. The clearance of a substance is of a marker substance that is not metabolized by the kidney. Right, can be used to measure the volume of arterial plasma that is completely cleared of that substance in unit time, usually in 1 minute. All right, so basically we are saying that to measure glomerular filtration rate, we'll need to employ a substance that is filtered. that the kidney will filter, right? That it will move, so it will move from the blood in the glomerular capillary to move across the filtration membrane into the urine, and this substance is not metabolized by the kidney. It's not metabolized by the kidney. It's not secreted by the tubules. All right. So once we do that, we can measure the clearance of that substance by doing a calculation on the urinary concentration of that substance, the urine flow, the urine volume per minute, that's urine flow, and the plasma concentration. So those three things are needed to calculate the clearance of that substance and thus calculate the glomerular filtration rate of the subject. All right. So any substance that that will be used to measure glomerular filtration rate should ideally have the following properties. It should not be metabolized by the kidneys. It should be freely filtered at the glomerulus. All right. There should be no protein binding. It should not have any effect on the glomerular filtration rate. It should not be reabsorbed. Neither should it be secreted or metabolized by the renal tubule, and so on. All right. So let's now let's look at the measurement of GFR. So, like we said, it is represented, the glomerular filtration rate in milliliters per minute is represented by the formula UV over P, where U is the concentration of the marker in the urine, V is the flow rate of urine, and P is the plasma concentration of the marker. So the clearance of either inulin or endogenous creatinine is usually used. Inulin will be the preferred method, but it's not routinely used in clinical practice because it's not how do I put it now? It's not a convenient process to do. It's not a very convenient process to do. So, but inulin will be the ideal substance to use. When you measure its clearance, then you can now calculate the GFR from that. Okay. So clearance can also be measured using other agents like 51, 51 EDTA and so on. So now, but using inulin. Now, inulin is a substance that is filtered. It's freely filtered across the filtration membrane, but it's not reabsorbed and is not secreted by the tubules. All right. So this is the equation again. GFR equals UV over P. Right. Where U is the urine concentration of inulin. That's U inulin times the V, which is the urine flow rate, over the plasma concentration of inulin. So an example, right? A patient is infused with inulin until a steady state plasma concentration of 1 milligrams per ml is achieved. All right. So a urine sample was collected over 1 hour, right, which had a volume of 60 ml and an inulin concentration of 120 milligram per ml. What is the patient's GFR? So basically, just follow the formula. GFR equals the urinary concentration of inulin times the urine flow rate over the plasma concentration of inulin. So that's just 120 milligram per ml times 60 milliliters per hour over 1 milligram per ml. So eventually you get this. All right. So that's just straightforward. So for this hypothetical patient, their glomerular filtration rate is simply 120 ml per minute. Okay. All right. So creatinine might be used too. All right. Usually for creatinine, using creatinine to measure glomerular filtration rate, a 24-hour urinary clearance is preferred. All right. So now creatinine comes from a substance called creatine, which is used for as a energy source within muscles. All right. So 1 to 2% of total muscle creatinine is converted daily to creatinine. So, but you note that Now, this same formula that we used to generate the GFR using inulin also applies to creatinine. Yes, so we need to know the flow rate, we need to know the plasma concentration of creatinine, and we need to know the urinary concentration of creatinine. But creatinine clearance overestimates GFR by about 10 to 20%, because about 10 to 20% of urinary creatinine is secreted, not filtered. So it means that whatever amount of creatinine that we find in the urine, it's only about 80 to 90% of that creatinine that was filtered. The other 10%, the other 10 to 20% was secreted from the tubules into the urine. All right, so it means that creatinine is not an ideal, is not the best marker substance that we use to measure GFR, but it's much more convenient because it doesn't require getting an infusion of getting an infusion of inulin, setting up an infusion, infusing the patient for 1 hour, and so on. It's cheaper to use creatinine. It's cheaper and more convenient, and so but we just note this drawback. All right. So there are some factors that affect glomerular filtration. All right. So the characteristics of the filtration membrane, this stands to reason. The composition of the glomerular filtrate, dynamics of glomerular filtration, the glomerular filtration rate itself, the filtration fraction, and other. All right. So let's start with the characteristics of the filtration membrane. All right. So the structure. Right, as we've talked about earlier, the membrane consists of the endothelium that has relatively large pores. All right, so now there are 3 layers to the filtration membrane. The first is the endothelium, right, of the glomerular capillary. Now, all right, now for this, the solutes like electrolyte or other things, plasma proteins and fluid can pass through the endothelium, but not blood cells. All right, so the endothelium prevents blood cells from passing through. Now, the glomerular basement membrane is the second layer of the filtration membrane. Now, this prevents proteins from being filtered out. So proteins can pass through the pores in the endothelium, but are not able to pass through the glomerular basement membrane, and so proteins will normally not be seen in kidney. Or it's not as if they are not seen, but the quantity seen is very very small in the normal kidneys. All right. Then finally we have the podocytes. Right. So the podocytes, as shown here, we said they have food processes which wrap around the capillaries but leave spaces in between them, which is referred to as the filtration slit. So these are filtration slits. So we can see this pink thing here is the blood, right? And these are endothelial. This is the endothelium of the capillary, and these are the spaces in between them, right? That we refer to as filtration pores, right? So we said that that a red blood cell is too big to pass through this pore, right? But proteins or any other dissolved substance can pass through this pore. So, but once they pass through the pore of the endothelium and they get to the glomerular basement membrane, those proteins that were able to pass through the endothelium cannot go beyond the glomerular basement membrane. But the other things, the solutes and the other things, can pass through. All right, so now this is the filtration slit. Now there's a thin diaphragm called the slit diaphragm, which acts as a final filtration barrier. All right, the slit diaphragm covers the filtration slits, and once the filter fluid passes through the slit diaphragm, then they enter into the glomerular space. All right, so this shows a scanning electron micrograph of a renal corpuscle. So this is how a renal corpuscle looks like in real life. Oh, of course, this is black and white, so I'm sure the real life colors are actually they will have colors as tissues, but in black and white, this is how they look like. So these are actual, or this is an actual renal corpuscle shown here, as it will look like, except that this is in black and white. All right. So this is a podocyte. You can see the cell body, and you can see the processes, fruit processes. Right. All right. All right. Still on characteristics of the filtration membrane. Yes. Then we also have the permeability. Um, okay. And we also have so the glomerular filtration is highly permeable. The filtration membrane is highly permeable to water, solute, and what are small molecules, but not to big molecules. Then the charge selectivity, we've talked about this earlier. So normally the protein excretion in urine is very small. It's less than 100 milligrams per day. So it doesn't mean that there will be no protein at all, because there are some very small. There are some protein molecules that are they're actually of very small size, right? So some of this will pass through the filtration membrane, right? So, but you should note that the filtration membrane, the permeability of the filtration membrane is altered in diseases, which will lead to from passage of proteins to increase, right? And albumin will increase in the urine, which we refer to as albuminuria or proteinuria. All right. So now the dynamics of glomerular filtration as a factor that affects glomerular filtration rate. Now, there are some forces that favor filtration, and there are some forces that are opposite. We talk about Stalin forces. All right. So there is a glomerular. Okay, let's go ahead here. Let's have a look at this. Now, this here is the afferent arteriole bringing blood into the glomerulus, and this is the efferent arteriole taking blood out of it. All right. So within the glomerulus, the glomerular capillary, the hydrostatic pressure, that's the BHP, that's the blood hydrostatic pressure, will tend to push. Is a force that tends to favors filtration, because the higher the pressure, the blood pressure coming in from the afferent arteriole, then the higher will be the blood hydrostatic pressure. All right. So we find out that in this particular cartoon, find that the blood hydrostatic pressure, which is pushing filtration, is about 60 millimeters of mercury. All right. Then we also have capsular hydrostatic pressure. So the urine that has already formed within the capsule, also its own pressure too will tend to push back into the glomerulus, and so the capsular hydrostatic pressure will oppose filtration. All right. So then we have the colloid osmotic pressure, because we said that the proteins largely will not move into will not be filtered, and so the proteins within the blood in glomerular capillaries, they have osmotic effect, or which we refer to as oncotic effect. They will tend to draw water towards themselves, and so they will tend to pull water from the capsular space into the capillary, into the glomerular capillary, and so that force, that oncotic pressure, also opposes filtration. So, but in this case, we find out that the force pushing filtration is 60 millimeters of mercury, but the forces opposing filtration are altogether 50 millimeters of mercury in total, and so the net filtration pressure will now be 10 millimeters of mercury. That is the net filtration pressure. That's your 60 minus 32 minus 18, which give 10. All right. So forces favoring filtration, we have the glomerular capillary hydrostatic pressure, which is 60. Then hypothetically, Bowman's capsule colloid osmotic pressure. Now, this Bowman's capsule is assuming that there were protein molecules within the urine in the Bowman's capsule, in the Bowman's space, right? Then those protein molecules there will favor filtration. But we said that normally in health, the protein that you find in urine is actually so small that for all intents and purposes we can regard the oncotic pressure of protein within the urine as zero. It's not as if there is absolutely no protein there, but they are so small. The quantity is so small. All right. So the forces that oppose filtration, yes, the Bowman's capsule hydrostatic pressure and the glomerular capillary colloid pressure. So by the time you add everything, add and subtract everything together, you eventually get net filtration pressure to be 10 millimeters of mercury. Okay, so this shows similar thing. All right. So what we just discussed is they are referred to as Stirling forces. So the Stirling forces are hydrostatic and the oncotic pressures. Now, Stirling hypothesis states that the net filtration through a capillary membrane is proportional to hydrostatic pressure difference across the membrane minus oncotic pressure difference. So hydrostatic pressure is a pressure of the force that is generated by the pressure of the fluid, whereas the oncotic pressure difference is the osmotic force generated by osmotically active protein molecules within the fluid on both sides of the membrane. Okay. All right. So all the forces involved in glomerular filtration are referred to as Stirling forces, and the net filtration pressure, as we've said earlier, is basically you calculate it by adding and subtracting the forces that favor filtration and the forces that oppose filtration. All right. So now hydrostatic pressure within the glomerular capillaries is the glomerular capillary pressure. We said this earlier, and we also said that all the pressures that are involved in determining the filtration rate, they are referred to as the Stirling forces. All right. So the first equation we see here, we've already alluded to it earlier. Net filtration pressure equals to the hydrostatic pressure within the glomerular capillaries, right, minus the hydrostatic pressure within the Bowman space. All right. So that will give you the net hydrostatic pressure. All right. Now you now subtract from this the oncotic pressure within the glomerular space minus the oncotic pressure within Bowman's capsule. Now, as we said earlier, usually there is little to no oncotic pressure within Bowman's space, and so this particular component of it should normally be zero, approaching zero. So we just use zero for it. All right. And so the glomerular filtration rate will now be what? It will be the filtration coefficient times the net filtration pressure, because everything here stands for the net filtration pressure. All right. So glomerular filtration rate is filtration coefficient times net filtration pressure. All right. So GFR, based on the values we've already stated earlier, so assuming that the filtration coefficient is 12.5, as we said earlier, and the net filtration pressure is 10, because this 60 minus 18 minus 32 minus 0 will give us 10, and so we find that the glomerular filtration rate, we derive 125 mL per minute. Okay, so as I said, the PGC stands for the glomerular capillary hydrostatic pressure, which is a force that favors filtration, whereas the Bowman space hydrostatic pressure opposes filtration. The glomerular capillary oncotic pressure opposes filtration. The Bowman space oncotic pressure, which is usually 0, favors filtration. So, but of course, this can be more than 0 in cases of glomerular diseases that allow protein to leak, to pass through the filtration membrane into the Bowman's space. Now, normal GFR is usually around 125 mils per minute, but you should note that it's a range. It's a range. There is no, in fact, there is virtually, at least I can't recollect any value in the human body that is a fixed value. Most things are a range, a normal range. All right. So it's about 10% lower in women when compared with men. All right. Now, you should know that if the one might think that the higher the GFR, the higher the glomerular filtration rate, the better the health of the individual, the better the health of the kidneys of the subject. Yes, but there's such a thing as it's possible for the glomerular filtration rate to be too high. Right? Yeah, and it will, if it's too high, it will cause some issues. All right. Now, if the GFR is too high, the substances that are meant to be reabsorbed will not be able to. They will not be reabsorbed quickly enough, right? As the flow, the urine flow will be so fast that the tubules will not have time to reabsorb the substances that the body wants to keep. All right, and so this will be lost in the urine. But on the other hand, if the filtration rate is too low, then everything is reabsorbed, including waste products that should normally be disposed of. If the GFR is too low, the urine flow rate, the flow rate of the filtrate through the tubules will be so slow that a lot of the waste products that should be excreted will actually be reabsorbed. All right. Now, the filtration fraction is also a determinant of GFR, and it's the ratio of the GFR to renal plasma flow. Okay. Okay. So if we have a value of 125 mils per minute for the glomerular filtration rate, and we have 650 mils per minute for renal plasma flow. Remember, at some point we said that the renal blood flow was between 600 to 1,200 mils per minute. Okay, so at rest it might be something around 650 thereabouts mils per minute. So if you are to divide this, right, 125 divided by 60, you get a filtration fraction of 0.2. Okay, and the higher the filtration fraction, then the higher there will be reabsorption, right, in the proximal convoluted tubules. All right. So the renal blood flow is an important factor that, in fact, probably the most important factor that affects the glomerular filtration rate, because everything depends on blood flow. The whole process of glomerular filtration depends on blood flowing through entering the glomerulus through the afferent arteriole, right, and being filtered across the filtration membrane. All right, so the flow of blood, the renal blood flow, is the most important thing that influences the filtration rate. The other thing is tubuloglomerular feedback, all right, which is a mechanism that regulates glomerular filtration rate through the renal tubule and macula densa. We'll talk about this in the next few slides. Okay. Then the filtration coefficient as well. All right, so the filtration coefficient, of course, it's will be determined by the characteristics of the filtration membrane. All right. So if you are trying to filter something, it doesn't have to be within a biological system. If you are filtering something, say in a laboratory or in industry, for instance, whatever the filter is will have a filtration coefficient, and that coefficient will be determined by the properties, by the characteristics of the filtration membrane. All right. But in this case, in the case of the kidney, the filtration coefficient is the glomerular filtration rate in terms of net filtration pressure. Right? It is the glomerular filtration rate per millimeters of mercury of net filtration pressure. So recall that we said that that the glomerular filtration rate equals the filtration coefficient times the net filtration pressure. All right. So it means that filtration coefficient will be glomerular filtration rate divided by the net filtration pressure. Like if you just if we rearrange this, we know that GFR equals filtration coefficient times all of this will equals to net filtration pressure. All right. So if you rearrange the equation, we'll find out that filtration coefficient will equal glomerular filtration rate divided by net filtration pressure. Okay, so if you calculate it based on these values, right, where GFR is 125 mils per minute and the net filtration pressure is 20 millimeters per 20 millimeter mercury. So if you divide that 125 divided by 20 will give 6.2 mils per millimeters of mercury. All right. So if the filtration coefficient increases, then the GFR will also increase, and if the filtration coefficient decreases, GFR also decreases. Some things that might change, might affect the filtration coefficient includes things like hypoxia, toxic agents, increase in colloidal osmotic pressure, and so on. Okay. Yes. Then we should also know that if the capillary membrane is thickened, right, there are some disease entities that might cause thickening of the capillary membrane. This will decrease permeability of the filtration membrane, and thus it will reduce the filtration coefficient. All right. Also, filtration area. All right. That's the size of the capillary bed will affect the filtration coefficient. All right. Okay. Now, the filtration area can be physiologically reduced when there is contraction of messenger cells due to release of vasoconstrictor. Okay. So let's give an example now. For instance, if an individual was to be having an hemorrhage, say, maybe somebody involved in a road traffic accident and is bleeding, right? So there will be loss of volume, and there will be a reduction in the systemic blood pressure. Now, at that point, the adaptive mechanisms of the body will want to retain conserve fluid, and so it will be in the interest of the body to reduce glomerular filtration, because the higher the glomerular filtration, the more fluid is lost from the body, from the intravascular system as urine. All right. So in a situation where the blood pressure is going down and the intravascular volume is being lost from hemorrhage, then the adaptive systems of the body will cause contraction, vasoconstriction of the afferent arterioles, right, which will reduce among other things, it will reduce the renal plasma flow. It will also reduce the size of the capillary bed, thereby reducing filtration coefficient and reducing glomerular filtration rate. Now, the hydrostatic pressures in Bowman space, we've already talked about this, so I will not dwell on this, as well as the other pressures. Okay. All right. So, yes, let's just note what happens when you have constriction of either the afferent or efferent arteriole. When the afferent arteriole is constricted, right, the blood flow to the glomerular capillaries reduces, and that will reduce the GFR. But if the efferent arteriole is constricted, there will initially be an increase in GFR, right? Because it's, when you constrict the efferent arteriole, it means that you are preventing the exit of blood from inside the glomerular capillary, right? And so that temporarily increases the glomerular filtration rate. So, but eventually that blood within the that is prevented from exiting the glomerular capillary by the constriction of the afferent arteriole. Eventually, that blood will, a lot of things will be, they will be reabsorbed. There will be the substances inside will be reabsorbed, and eventually the pressure, the initially increased pressure due to the vasoconstriction of the afferent arteriole will actually go down, and there will be a cessation of filtration. All right, there will be a cessation of filtration because no fresh blood will enter the glomerulus for filtration. Now, there's also the systemic arterial pressure also has an effect, also has a role to play on glomerular filtration rate, because the kidneys, even though they have a unique circulatory system, is still part of the systemic circulation, and from the autoregulation of the renal blood flow means that the GFR and renal blood flow is not affected as long as the mean arterial pressure of systemic circulation is between 60 to 180 millimeters of mercury. All right. So, but anything beyond this, either on more than 180 or less than 60, it affects the renal blood flow and glomerular filtration rate because the autoregulatory mechanisms, they fail beyond this range. All right. So, if systemic blood pressure was to increase to the mean arterial pressure of systemic circulation was to increase to 170, the autoregulatory mechanisms of renal circulation can ensure that the renal blood flow does not increase to a point where it will compromise the functions of the kidney. Remember that we said that glomerular filtration rate can be too high. So if glomerular filtration rate was to increase proportionately due to the increase in systemic blood pressure, so if it was increased proportionately, then it will result in a GFR that is too high. And remember what we said, that if it's too high, the kidneys will not be able to reabsorb the needed the substances that the body wants to conserve, wants to prevent from being excreted. All right. So, and and if the blood pressure was too low, systemic blood pressure was too low, lower than 60, that's the mean arterial pressure, then the autoregulatory mechanisms will also fail too, and that will lead to GFR that is too low, and it also cause damage to the kidney and its function. Now, there are hormonal factors that also affect glomerular filtration rate. All right, so they include things. There are some that increase the rate by vasodilation, such as the atrial and brain natriuretic peptide, cyclic AMP, dopamine, prostaglandin E2. There's also other factors that decrease GFR by vasoconstriction, such as angiotensin 2, noradrenaline, platelet activating factor, prostaglandin F2. and so on. Okay, so again, if the GFR is too high, fluid flows through the tubules too rapidly to be absorbed, urine output rises, and it creates threat of dehydration and electrolyte depletion. But if the GFR is too low, the flow is sluggish, the tubules reabsorb waste that should be normally eliminated, and azotemia, azotemia develops. Azotemia is just a higher than normal concentration of nitrogenous waste substances, waste products in the blood. Okay. Now, let's talk about regulation of glomerular filtration rate. Now, from this equation, glomerular filtration rate equals filtration coefficient times the net filtration pressure. Any factor that affects this parameter, any of these parameters, will affect glomerular filtration rate. But physiologically, regulation of the GFR involves mechanisms that affect mainly the hydrostatic pressure within the glomerular capillaries. So PGC stands for glomerular capillaries hydrostatic pressure. All right. So and this pressure, it depends on the arterial blood pressure and the resistance of both the afferent and efferent arterioles. All right. So you can see a cartoon here showing it's showing a schematic diagram of glomerulus. This is the afferent arteriole and this is the efferent arteriole. Okay. All right. So if we constrict the afferent arteriole, right, which is illustrated here, it will decrease the hydrostatic pressure within the glomerular capillaries, all right, which will thus decrease the glomerular filtration rate. So some of the things we listed earlier that can cause vasoconstriction, with this, some of them. But if you are to constrict the efferent arterioles, right? So if the constriction is moderate, if it's moderate or if it's just for a brief period of time, yes, it will increase the hydrostatic pressure within the glomerulus and thus increase the GFR. But if the constriction of the efferent arteriole is severe, either it is severe or the constriction not necessarily severe but for a longer time, eventually it will cause reduction in the hydrostatic pressure within the glomerulus and eventually reduce the GFR. Okay. All right. So the now that we know that the way the body regulates GFR is to cause selective vasoconstriction or dilation of the arterioles, afferent and efferent arterioles. Now we should know that the body employs two groups of mechanisms to regulate the GFR. All right, and they are either intrinsic mechanisms, all right, also called renal autoregulation, or extrinsic mechanisms. So extrinsic mechanisms they originate outside of the kidney, right? They involve the nervous and endocrine systems, whereas intrinsic mechanisms, as the name suggests, the kidney can auto-regulate its own blood flow, and the mechanism by which it does that are referred to as intrinsic mechanisms. All right, so we'll talk about the intrinsic mechanisms first on autoregulation. Okay, so these are responses that are initiated by the renal structures themselves to modify the hydrostatic capillary pressures, and that is what we refer to as renal autoregulation. They maintain near constant GFR when the mean arterial pressure is 80 to 180 millimeters. Okay, some authorities will say 60 to 180 millimeters of mercury. All right, so this allows for consistent kidney function despite changes in blood pressure. Okay, the another thing that we should note is that if blood pressure is too low, and right now, apart from leading to a failure of filtration, the uh, remember that the peritubular capillaries, they supply nutrients to the tubules. So if the blood pressure in them is too low, then the oxygen and nutrient supply to the tubules, to the glomerulus itself and to the tubules will be compromised, and that can actually lead to death, necrosis. There's a clinical entity called acute tubular necrosis. It can result from compromise in blood supply. All right. So now, during daily activities, cardiac output and arterial blood pressure fluctuates. Yes, we know that cardiac output can increase several times, uh, by several magnitude, during exercise, and it goes down during sleep. All right. So, but the kidneys are meant to continue to function irrespective of changes in cardiac output, either increases or decreases. All right. So if these increases or decreases are within, uh, they are within reasonable limits, the kidneys can adjust and continue to work optimally, or close to optimally. All right. So this shows what we're talking about, that even when the autoregulation is able to maintain GFR at a constant level or near constant level, uh, when when systemic mean arterial pressure ranges from between 80, okay, well, most authorities will say 80 to 180, so just disregard the 160 here. So, but it means that for a wide range of variation of mean arterial pressure of the systemic circulation, autoregulatory mechanisms in the kidneys is able to maintain GFR at a constant or near constant level. All right. So, when the blood pressure is very high, autoregulation protects the glomerulus from damage, and at lower blood pressure, it ensures that the kidney can get enough blood to filter waste. All right. So there are two extrinsic mechanisms. The first is the myogenic mechanism. All right. So now we'll talk about the myogenic mechanism, one of the two mechanisms of renal blood flow autoregulation. Myogenic mechanism is simply the intrinsic ability of blood vessels to constrict on reflex when the blood pressure is increased. Right? This constriction, which will cause which are referred to as vasoconstriction, will prevent an excess increase in renal blood flow that may damage the glomerulus. Now, how does this happen? We know that the walls of arteries in the body have smooth muscle within them, right? And so, what happens is that when there is increased renal blood flow, this will lead to an increased tension on the walls of the arterioles, right? There are stretch receptors within the walls of the arterioles. Stretch receptors are mechanoreceptors. When these stretch receptors are stimulated by the increased tension, they cause reflex contraction of the vascular smooth muscle, thereby causing vasoconstriction. The mechanism by which this happens involves movement of calcium ions. So basically the stretch receptors generate a signal that leads to opening of calcium channels, which permits calcium to flood into the cells, into the smooth muscle cells from the extracellular compartment, and thereby initiating contraction. And whenever the renal blood flow is low, the stretch receptors are inactivated because the tension on the walls of the arterioles will reduce, will go back to normal, and with inactivation of the receptors, the afferent arteriole dilates to increase the glomerular filtration rate. Here's a cartoon illustrating what we're talking about. This is the afferent arteriole, the renal blood flow. Now, as blood flows through the afferent arteriole, it is exerting a pressure on the walls of the arterioles, right? And that same pressure, when exerted within the part of within the glomerular capillary, that pressure of the blood is what is driving the filtration. Basically, that is the hydrostatic pressure of blood within the glomerular capillary, and that's the chief driver of filtration. So, for this particular cartoon, what happens when the afferent arteriole is vasoconstricted? All right, so this is the vasoconstriction of the afferent arteriole. The arteriole bringing carrying blood into the glomerulus. So what will happen? It will lead to a decrease. As we decrease the renal blood flow, it will decrease the glomerular hydrostatic pressure, and thereby decreasing the glomerular filtration rate. So this is what happens when you reduce the when you cause vasoconstriction in the afferent arteriole. This is what happens. The hydrostatic pressure within the glomerulus reduces, and the GFR. All right, so let's now talk about the effect of arteriolar vasoconstriction and vasodilatation actually on GFR, whether it is afferent or efferent. Now, this first instance here is what happens, the situation when is a normal situation where the afferent arteriole and the efferent arterioles are at their normal diameter. The resistance is the vascular resistance is normal. Right now, in instance A here, we have already discussed this in the previous slide. What happens when the afferent arteriole is constricted? Now, this leads to, as we said earlier, to reduction in the glomerular hydrostatic pressure, and thus reduction in renal blood flow and GFR. Now, in instance B is what happens when there is vasoconstriction of the efferent arterioles. All right, so this will lead to a increase in the glomerular hydrostatic pressure, but a decrease in the renal blood flow, as well as and an increase in GFR. So basically, whatever we increase the glomerular hydrostatic pressure, we always increase the GFR. So when this efferent arteriole is constricted, now that will lead to a reduction in renal blood flow, because the blood is flowing in this direction. So whether you constrict at this point, which is in the afferent arteriole, or you constrict here, which is in the whether you constrict here, which is in the afferent arteriole, or you constrict here in the efferent arteriole, it will still result in reduction in the flow of blood, reduction in renal blood flow. All right, so efferent arteriolar constriction will cause a reduction in renal blood flow, but because the flow of blood out of the glomerulus is obstructed by this constriction at this point, it will lead to an increase in pressure within the glomerulus, which will thus increase the glomerular hydrostatic pressure, right, and thus increase the GFR. Now, in the third option, in the option C, situation C here, when the efferent arteriole is dilated, right, as you can see here. All right, so this dilation will increase the renal blood flow, because as blood is flowing through here from the afferent to the efferent arteriole, when you dilate any part of the passage of dilate any part of the arterioles, it will lead to increase in the flow of blood, but it will also lead to reduced pressure. It will not, this dilatation will not allow pressure to build up within the glomerular capillary, right? And so if that pressure doesn't build up, it means that there will be a reduction in the glomerular capillary hydrostatic pressure. All right, so this will decrease, and therefore the GFR will also decrease. All right, so but what happens when you have finally here, when we have dilation of the afferent arteriole? Now this will cause an increase in all three parameters. Yes, the renal blood flow will increase, the glomerular hydrostatic pressure will increase, and the GFR will also increase. Now, the second mechanism of autoregulation is called the tubuloglomerular feedback mechanism, and this is where the juxtaglomerular apparatus comes into play. It relies on interaction between the juxtaglomerular apparatus cells, the tubules, and the glomerular arterioles. Right? So it involves a paracrine signaling mechanisms, which utilizes ATP and adenosine. Now, remember that we said earlier that juxtaglomerular cells, also called granular cells, they are modified smooth muscle cells within the afferent arteriole, and they can contract or relax. That is what muscles do, right? They contract or relax in response to signals that they get from the macular denser cells. All right, so these mechanisms will cause either contraction or relaxation of the afferent arteriolar smooth muscle cells, and thus this will regulate blood flow to the glomerulus. Now, the steps involved here is that when renal blood flow increases, when there's an increase in renal blood flow, the capillary hydrostatic pressure will also increase, and the glomerular filtration rate will increase. Now, as the glomerular filtration rate increases, there will be less time for sodium chloride, that salt, to be reabsorbed in the proximal convoluted tubule. Right? Remember that as the filtrate is passing down the tubules from the proximal convoluted tubule until it gets to the collecting duct, that the tubules will be absorbing, there will be reabsorption of sodium chloride and other elements with inside electrolyte, nutrient, and other things inside the filtrate. Now, because of this increased glomerular filtration rates here, there will be less time for the sodium chloride to be reabsorbed in the proximal tubules, and thus the osmolarity of the filtrate that reaches the distal tubule will be higher. There will be more sodium chloride in the filtrate that reaches the distal tubule, where the macular denser cells are located. Now, the macular denser cells in the distal tubule, they can sense that there is an increase in the concentration of sodium chloride within the filtrate. All right, and then they respond by releasing ATP and adenosine. Now, ATP and adenosine, they act locally, and that's why we refer to them as paracrine factors. They act locally to stimulate the JG cells, right, the juxtaglomerular cells, which, remember, we said they are modified smooth muscle cells. So the ATP and adenosine stimulate these cells in the afferent arteriole to constrict, which will therefore reduce renal blood flow and thus reduce GFR. Alright, and so with the reduction in the glomerular filtration rate, the tubules have more time for sodium reabsorption. Now, conversely, when the opposite happens, when GFR reduces, then the proximal tubules will have more time to reabsorb sodium chloride, and so there will be less sodium chloride in the filtrate that reaches the distal tubule, right? And so the macular denser will sense this and will reduce their secretion of their release of ATP and adenosine, which will allow the afferent arteriole to dilate, and thus there will be an increase in GFR. Okay. In addition to this, the macular denser also secretes prostaglandin E2, a vasodilator that also contributes to dilation of the afferent arterioles. Okay, so this is an illustration of what we are talking about. When there's a decrease in renal blood flow, the glomerular hydrostatic pressure will also decrease, and thus there will be a decrease in GFR. When the GFR decreases, it means that there will be more reabsorption of sodium chloride. Right, so which means that the sodium chloride in the filtrate that gets to the macula densa will be reduced. All right, so the macula densa will now initiate several things that would lead to an increase in renal blood flow. Now let's talk about the extrinsic controls. Extrinsic controls. These are neural and hormonal mechanisms. Now, the extrinsic control mechanisms also have an effect on the GFR, but their primary function is to maintain systemic blood pressure. While the intrinsic controls function to they are specifically meant to control GFR at the level of the kidneys, the neural and hormonal controls of the intrinsic control system have a broader scope. Right? They function to meet the needs of the whole body and not just that of the kidneys. Now, the first is sympathetic nerves. The kidneys are innervated by sympathetic neurons of the autonomic nervous system. And a decrease in sympathetic stimulation will lead to vasodilation. Remember that we said earlier that normally arteries are normally always under some degree of sympathetic stimulation at baseline. Right, they're always under some degree of sympathetic stimulation. All right, so if there is a decrease in that baseline sympathetic stimulation, it will lead to vasodilation, because the baseline sympathetic stimulation causes a slight degree of vasoconstriction in arteries. So they're always slightly vasoconstricted because of this baseline sympathetic stimulation. So any reduction in this baseline sympathetic stimulation will cause vasodilation and thus increase blood flow through the kidneys during resting conditions. But if there is an increase in sympathetic stimulation, the opposite will happen. There will be vasoconstriction and reduced glomerular blood flow, and thus reduced GFR. Okay. Now, which under conditions of stress, we know that sympathetic nervous activity will increase, right? So this will be a general increase in sympathetic nervous activity in the whole body, right? So, and it will also affect the kidneys, as we've discussed in the last slide. All right. So this will result in direct vasoconstriction of the afferent arterioles, as well as the stimulation of the adrenal medulla. So during times of stress, when there's generalized there's a generalized increase in sympathetic nervous activity, the afferent arterioles will vasoconstrict. The adrenal medulla will also be stimulated, and it will also add to the vasoconstriction through release of epinephrine. Now, this epinephrine will spread in the blood to all the organs, all the tissues and organs of the body, including the kidneys. All right, and this will further lead to a further vasoconstriction of the afferent arterioles. Now, why does this happen? Now, it's because during times of stress, the body wants to redirect blood flow to only organs that are needed for immediate survival, as it were. We talk about the fight or flight. We say the sympathetic nervous system is the flight or fight division of the autonomic nervous system. So in times of danger, for instance, the body needs to redirect blood supply to the organs and tissues that are involved, that are life-saving. So, for instance, to the muscles, to the brain, to the heart, and so on. So, at that point, the kidneys are not necessarily high. They are not high on the priority, on the list of priority for the blood supply. So, now, under severe stress, such as in significant blood loss, the sympathetic nervous system kicks into high gear to keep the blood moving to essential organs and thus keeps the body alive. All right. So, but however, this general vasoconstriction that's required to maintain systemic blood pressure in these conditions can be damaging to the kidney tissues. Now, when somebody is losing blood, has hemorrhage and is losing blood, the blood pressure is going down. Perfusion of the organs they are not optimal, right? That is that's a situation of high stress, right? Now, the sympathetic nervous system will be stimulated strongly, right, and it will lead to vasoconstriction, which will involve the kidneys along with other organs. All right, so this will attempt to maintain the blood pressure, right, in organs that are needed to keep the body alive. All right, so this will affect the kidneys because it will reduce the blood supply to the kidneys because the kidneys are not regarded in times of extreme stress, such as this this hemorrhage. Kidneys are not regarded as essential, right? And so this can actually lead to damage to the kidney, even though the purpose of the widespread sympathetic activation is to help keep the body alive. Now, if the blood pressure falls, the sympathetic nerves will also stimulate the release of renin. Remember that we said that the juxtaglomerular cells, they contain renin, and they are also sympathetically innervated. Okay, so sympathetic activation will also stimulate the release of renin from these same cells. Okay, so in summary, when the sympathetic nervous system is at rest, the renal blood vessels are maximally dilated and autoregulation mechanisms prevail. But under times of stress, norepinephrine is released by the sympathetic nervous system. Norepinephrine is released by sympathetic innervation within the kidney, and epinephrine is released by adrenal medulla. Right, the afferent arterioles constrict under the influence of the sympathetic nervous system, and filtration is inhibited. And the sympathetic nervous system also stimulates the renin-angiotensin mechanism. This will induce vasoconstriction of the efferent arteriole. Remember that the renin-angiotensin mechanism will end up the final product of this pathway is angiotensin 2, and angiotensin 2 is a vasoconstrictor of the efferent arteriole. Now let's talk about the renin-angiotensin aldosterone mechanism, which is the prime example of the hormonal mechanisms of control of renal blood flow. Now, renin, as we said earlier, is produced by the juxtaglomerular cells, right, of the afferent arteriole of the juxtaglomerular apparatus. Now, it converts angiotensinogen, which is a pre-pro hormone, right? So it converts angiotensinogen into angiotensin 1, right? Angiotensin converting enzyme converts inactive angiotensin 1 to active angiotensin 2. Now, angiotensin converting enzyme is produced in the lungs, but is seen to bind to surface of endothelial cells within the kidneys. Now, angiotensin 2 is a potent vasoconstrictor, but in the kidney, systemically, it causes vasoconstriction of both afferent and efferent arterioles or of the glomerulus. However, the efferent arteriole constricts more strongly. So relatively, it's as if it only constricts the efferent arteriole. It actually constricts the two. It constricts both afferent and efferent arteriole, but it constricts the efferent arteriole more strongly. All right, and so the net effect is as if it is constricting just the efferent arteriole, and this will lead to increase in GFR. Okay, so this is what happens in the renin-angiotensin-aldosterone system when there's a drop in blood pressure, such as during times of hemorrhage. Right, the kidneys, the juxtaglomerular cells are stimulated. The sympathetic stimulation that happens in that time of stress will eventually lead to stimulation of juxtaglomerular cells, the JG cells, to secrete renin, and the renin-angiotensin-aldosterone system kicks into play. Now, apart from angiotensin 2 as one of its effects also stimulates the adrenal cortex to release aldosterone, and we all know what aldosterone does. Aldosterone causes what? Sodium and water retention. Remember that the initial stimulus that initiated this was a drop in blood pressure, and so when aldosterone causes water retention in the kidneys, that will tend to help increase the blood pressure. And sodium too. Remember that sodium will also draw water along. That will so the sodium and water retention will help to increase the blood pressure. Now, angiotensin 2 also has other effects. It also stimulates the hypothalamus to stimulate thirst, right? So it stimulates the thirst center, and the individual feels thirsty, and if they can, they try and get water to drink, right? The angiotensin 2 also causes vasoconstriction generally in the rest of the body, not just the kidneys. All right, so vasoconstriction will elevate the blood pressure within the systemic circulation. Okay, I think we've said this already. I think we can also, yes, okay, finally we should note that angiotensin 2 also stimulates the release of antidiuretic hormone from the posterior pituitary. Okay, we'll talk about the functions of angiotensin 2. Okay. All right. So yes, as we've said, angiotensin 2 will reduce both GFR and renal blood flow, thereby limiting fluid loss in times of blood loss or dehydration. Its release is usually stimulated by a decrease in blood pressure, and so its primary aim is to preserve adequate blood pressure. Okay, so and as I said earlier, aldosterone is also released from the adrenal cortex in response to angiotensin 2, or it might also be released directly in response to increased plasma potassium. Now, aldosterone promotes sodium reabsorption and the retention of water, while it promotes excretion of potassium. Okay, so because of this, renin has an immediate effect on blood pressure due to angiotensin 2 stimulated vasoconstriction, and a more prolonged effect through the actions of aldosterone to cause sodium and water retention. Okay, and finally, as I said, angiotensin 2 also stimulates the posterior pituitary to secrete antidiuretic hormone, and we know antidiuretic hormone will promote the recovery of water and will decrease urine volume, and thus help to maintain plasma osmolarity and blood pressure. Now, to end the lecture, we'll discuss some clinical correlates. We should note that changes in GFR are used to define and diagnose chronic kidney disease, right? And chronic kidney disease is just the irreversible kidney damage, which is persistent over at least 3 months, and it is staged as follows. There are 5 stages. Stage 3 has A and B, and the stages are as listed here. So in stage 1, there's already kidney disease, but the GFR may be normal or actually increased. Stage 2 has a mild reduction, in which GFR is between 60 to 89 milliliter per minute per 1.73 meter square, and so on. Now, the second clinical correlate is that the RAS, the renin-angiotensin-aldosterone system, can actually be pathophysiologic. Right now, RAS is meant to be life-saving in the case of systemic hypertension, for instance. But look at what happens during renal artery stenosis. When the renal artery is stenosed for some reason, right? This reduces the blood flow through the renal artery, right? So renal blood flow will be reduced. So what happens? The renin-angiotensin system activates to try and elevate the blood volume, right, and pressure throughout the body, because the glomerulus is not getting adequate. The blood flow to the glomerulus is inadequate. The renin-angiotensin system kicks in, right, to try and increase the blood pressure. Now, the blood pressure that will increase will not just be the blood pressure within the renal circulation, but it will it will also affect the systemic circulation. So this will lead to what we refer to as renovascular hypertension, and ironically, the increased blood pressure will eventually damage the kidney. It will actually damage the kidney and damage other organs of the body as well. A third clinical correlate is that some antihypertensive medications, they target the RAS. Examples of these are the angiotensin converting enzyme inhibitors, which inhibit ACE, which inhibits the angiotensin converting enzyme. It was found out that the angiotensin converting enzyme inhibitors can cause an irritating dry cough, and so ARBs were developed, angiotensin 2 receptor blockers, which block the angiotensin 2 type 1 receptors. All right. So the ACE inhibitors dilate the efferent arteriole. They dilate the efferent arteriole. You remember that that angiotensin 2 constricts the efferent arteriole. So if you use an ACE inhibitor, its effect will be to oppose the action of angiotensin 2, thereby it causing dilation of the efferent arteriole and thus decreasing GFR. Now, non-steroidal anti-inflammatory drugs, NSAIDs, also decrease GFR. The NSAIDs, they inhibit prostaglandin synthesis. All right. We know that prostaglandin I2 and prostaglandin E2, they normally dilate the afferent arteriole. So NSAIDs are afferent vasoconstrictors, right? And this will lead to a decrease in GFR. So we have a situation where we have two groups of drugs that both reduce GFR, but whereas the ACE inhibitors and the ARBs will reduce the GFR by dilating the efferent arteriole, then NSAIDs will reduce GFR by dilating the afferent arteriole. With that, we've come to the end of the lecture. Thank you so very much for listening. We will take questions when we meet in class. Thank you.